Good afternoon, everyone, and it's a great pleasure to be with you for this second webinar in the AFRICAI-RI project. And this webinar, today we have the pleasure to welcome Dr. Elena Marban Castro, okay, who is a postdoctoral researcher at the Barcelona Institute for Global Health. She held a PhD in translational medicine. Elena, you'll explain us what is translational medicine from the University of Barcelona and the ES Global. So her doctoral research focused on the clinical and social effects of Zika virus infection during pregnancy and childhood outcomes. She works from 2016 to 2022 at ES Global on epidemiological studies, clinical trials, mixed methods, and qualitative studies on vaccine preventable disease at the maternal and child health department. So in 2022, she joined the Foundation for Innovative New Diagnostic, an NGO based in Geneva, where she worked on the implementation of innovative screening and diagnostic tools for infection diseases like COVID-19, malaria, HIV, and hepatitis. She worked too on non-communicable diseases like diabetes type 1, and her experience extends across continents with emphasis on how to inform service delivery in resource-constrained settings by community perspective. And I think our project, AFRICAI-RI, is based on that. So she is an associate professor on global health at the University of Balearic Islands. Additionally, she co-founded and is the current president of Women in Global Health Spain. Since 2025, she came back to IS Global to work on studies using artificial intelligence-based diagnostics for malaria, neglected tropical diseases, tuberculosis, and respiratory diseases in Africa, and non-invasive tools for screening of meningitis. So, Elena, it is a pleasure for you to give you the floor and to know better about qualitative studies. You can go.
Thank you so much. Thanks for the very nice introduction. So yeah, we'll be starting to know what translational medicine is. That is basically the translation from evidence into practice. And this is what we'll be talking about today. So I've prepared this presentation very briefly to introduce the terms of implementation science, qualitative methods, and some others that we'll be using during the AFRICAI-RI study. I made this presentation for a non-technical audience, just to familiarize yourself with these terms that we'll be using from the LC working group, the ethical, legal, and societal implications. So let's start. Did you know that it takes an average of 17 years for evidence to be incorporated into practice? So it's like if you are having a baby at your home right now and you are publishing some clinical trial results, this might not be implemented until your baby gets to university. This is crazy, right? Something that we know right now that it works, it takes so long to be implemented in our healthcare settings. So these are the gaps that implementation science tried to solve to shorten this year gap, and we try to understand the whys and the hows. For example, why do some interventions work and why others don't? And how do we make sure that what actually works gets implemented in our setting, in our healthcare systems, for example? So what's implementation science? It's the study of how to close that gap, how to build a bridge between the evidence and the practical use. And we try to take those strategies that work to make them work in a sustained way for the following years consistently in a real-world setting. So very different from a clinical trial perspective where you have everything under control. Another example from our day-to-day life is that having a great recipe, it does not mean that you can do this recipe, right? You need to adapt it, you need to cook it in your kitchen, with your oven, for your family, so you need some context to make this work. This is the same for the healthcare interventions. So implementation science is the study of the methods that promote the systematic uptake of research findings and other real-world evidence-based practices into routine of care to improve the quality of and the effectiveness of health services and care. So this is applied to different fields such as health, education, public policy, social services, and many others. And we use some frameworks to help us understand why some of these interventions work and others don't. So as if we were in Barbie land, implementation science would take us to the real world. There are many different concepts within the field of implementation science, and here I would just like to focus on this as some introductory examples. So within the AFRICAI-RI project, we aim to establish the first comprehensive open imaging repository in sub-Saharan Africa to target the enhancement of diagnostic accuracy and healthcare delivery for respiratory diseases such as tuberculosis and others. Some of the questions that could come to our mind are like, will the potential end users use this tool and how? Will users be applying this system that we are working, the way that it was designed to work? Will this still be working in 5, 10, 20 years or not? So these are some of the questions that we could have and that we will try to solve. There are several frameworks for implementation science, and you can look in the internet and you will find thousands. Well, maybe not thousands, but a lot of them. And they depend on our ultimate goal. So we can use them to evaluate barriers and facilitators, to design the strategy or the study that we'll be applying, to evaluate feasibility and other implementation outcomes, and also to assess or evaluate the context. So we can use them since the very beginning to, for example, frame the research questions, to help us develop the research tools, during data collection and also during data analysis. It's very important to know at which stage we would like to use this framework, for which objective, and then to use them. Also important to say that we can use different frameworks for different objectives throughout one study. So researchers have developed these structured ways to think about implementation, and one of the most commonly applied frameworks is a consolidated framework for implementation research. That is a determinant framework that includes constructs from many implementation theories, models, and frameworks, and it is used to predict or explain barriers and facilitators to implementation success. So I just wanted to stop here and say, when we refer to barriers, we refer to all the factors that affect negatively an implementation, and the facilitators are the factors that enhance or motivate or positively affect that the intervention is being success. So the consolidated framework for implementation research talk about these different themes. The process are the activities and strategies used to implement the innovation. The innovation in our case would be the OpenAI repository for medical imaging for respiratory disease diagnosis. The innovation is the thing that is being implemented, so specifically the system or the OpenAI tool. Then the individuals would be the roles and the characteristics of the individuals that will be involved using this innovation, like staff, healthcare professionals, IT people. Then the inner setting would be where the innovation is being implemented, the actual centers or the places where this would be implemented, and the outer setting would be the setting in which the inner setting exists. So more like the healthcare level or at the community level, for example. But we have other frameworks. We have, for example, the REAIM framework to encourage stakeholders to pay attention to some essential program elements, including external validity that can improve the sustainable adoption and implementation of interventions that are effective, generalizable, and evidence-based. It focused on these themes: reach, which is the number, proportion, and representativeness of individuals who are willing to participate in the initiative. Also, the effectiveness or efficacy, that it's considered the impact of an intervention on important outcomes, such as potential negative effects, quality of life, economic outcomes. Then the adoption, which talks about the number, proportion, and representativeness of settings and intervention agents, such as people who deliver the program, who are willing to initiate it. The implementation could refer at the setting level to the intervention agent's fidelity to the elements of the protocol, consistency of the delivery as it was intended to be used, the time and the cost that it takes, but also at the individual level, it can refer to the potential end users or the client's use of this specific strategy or intervention. And then we have the maintenance, the extent to which a program or policy becomes institutionalized or part of the routine organizational practices and policies. So we would like to show you another implementation science framework, that is the implementation outcomes by Enola Proctor et al. And here we can see the outcomes are defined here as acceptability, adoption, appropriateness, cost, feasibility, fidelity, penetration, and sustainability. From these implementation outcomes, then we have the service outcomes that talk about the service itself, such as efficiency, safety, effectiveness, equity, patient-centered, and timeliness. And then we have the user, the client outcomes, such as satisfaction, function, and symptomatology. And in the following table, we can see how these are structured. So, for example, when we talk about acceptability, we're talking about satisfaction with some aspects of this innovation, such as the content, the complexity, the comfort, the credibility, and we can use quantitative surveys to measure acceptability, but also qualitative interviews and other types of methods. When we talk about adoption, some synonyms or other terms that are used in the literature are uptake or utilization, initial implementation, or intention to try. And we can use both as well, quantitative and qualitative methods, such as surveys, interviews, or others. Appropriateness is defined as the perceived fit, the relevance, the compatibility, suitability, usefulness, or practicability of the intervention. Feasibility refers to the actual fit or utility, the suitability for everyday use, and practicability. Then we have other implementation outcomes, such as fidelity, that is the delivered as intended, the adherence to the strategy, the integrity, the quality of the program delivery. We have implementation cost, that talks, as you might know, about cost effectiveness, cost benefit, the marginal cost. Then we have penetration, that could be measures such as institutionalization, spread, service access. And then sustainability, that talks about the maintenance in the long term, the durability or continuation, incorporation of the program. Sometimes we also use the term scale up of the intervention, because we do not want that one intervention is done and then in 3 years' time is not used again. So as you can see, we are using both measures, quantitative and qualitative, to explain this. And something that I wanted to emphasize are the differences between surveys and interviews, and later we will also be focusing on quantitative data and qualitative data. So for example, if I put this table here, and if I would ask you to say, what do you think this is, a survey or an interview? Do you think this is capturing quantitative or qualitative data? This might be a little tricky because we have words as the questions from 1 to 4, and then also words to define the potential responses. But this is a survey. okay? Because this is a survey that uses a Likert scale from 1 to 5. So this completely agree until completely agree, disagree to agree. It can be numbered from 1 to 5. So it can be categorized differently if we are talking, for example, about acceptability, so the same framework, but here we are asking questions such as, how do you feel about the idea of uploading medical images? What would how would the platform fit in your setting, in your country, in your lab? How do you think other people, like patients, caregivers, or community members, would feel about us sharing their medical images for an AI platform to help diagnosis? So if you somehow understand the differences between the previous question, that it's like a 1 to 5 measure, and this one that is open-ended questions, a little bit more in depth, you are already gathering the differences between the quanti and the quali, the surveys, and the interviews. This is an interview. This is a semi-structured interview that we might be using for our study. So we know we need to understand the context, and we know we need to listen to the people involved. And what do we know from implementation science that can be related to qualitative research? So implementation science tells us what needs to be understood or which is the context that we might need. And then the qualitative methods tell us how to understand or how to address this. So let's start talking a little bit now about qualitative research. In this slide, I wanted to focus a little bit more on quali and quanti. Sorry, the red one, the orange one, should be quantitative, okay? So within quantitative research, we measure, we test, we do hypothesis testing, we generalize, we try to answer questions such as how many people, how much, and then the responses or the outputs that we get are numbers, frequencies, outcomes. We are many times talking about the p-values. We want statistical significance, we want representativeness, we would like always to have large sample size in order our results to be generalizable, comparable, and replicable. The limitation here is that sometimes we are missing the context and we are missing some of the mechanism and the whys these are working. But I understand that most of you might be more familiar with the quantitative methods, and now we'll be focusing on the qualitative one, so the green part. The qualitative methods are aimed to understand the meaning or the context, and we are aiming to respond to these questions. Why? How? What does it mean? So it goes a little bit more in depth. We analyze people's narratives, words, images, even observations. We usually have small samples, purposive, that allow us to go in depth in one specific topic. And it captures the complexity and the lived experience of those who experience something, like a diagnosis, a treatment, or anything. The limitation here is that it's hard to generalize and it's very resource intensive because you need to adapt the context to everything that you do. So qualitative research is used by several disciplines: anthropology, sociology, history, psychology, healthcare, education, economics, geography, and many others. And within our field of global or public health, we use it to explore health behaviors, to further understand the social context of interventions, and to describe processes of providing health interventions. I just put here in a different color these verbs because these are the ones that we usually use in qualitative research to explore, further understand, and to describe. We don't want to measure something in comparison to quantitative research. Some of the questions that might arise from a qualitative perspective regarding to the AFRICAI-RI project is why this intervention is not successful in this setting or in this country, why TB, tuberculosis, is not being treated if people have the treatments available, why will this community accept or not this strategy for medical data sharing, how do people react when they are diagnosed with TB, how do people understand their TB diagnosis and their treatment regimen, who takes the medical decisions in the family or in the community, and how can that influence uptake of our study. So we know that there are many different factors, cultural, socioeconomic ones, psychosocial, cognitive. There are social determinants like people's age, gender, and others, ethnicity, and also behavioral. And all of these factors will affect the outcomes. And when we talk about outcomes, we talk about acceptability, access, adherence, usability, satisfaction, and many others that we've seen previously in the implementation science slides. So qualitative research talks about research questions more than hypotheses or hypothesis testing. We usually tend to use inductive approaches. So we rely on the data itself to generate the theory or to generate the story. For example, theoretical generalizations that emerge from the data rather than being already assuming something beforehand. And this is the concept of grounded theory that we'll be looking at it right now. Sometimes we can also use inductive and deductive reasoning for data analysis. So within the inductive, there are no previous assumptions, and then results emerge from the data, and deductive assumptions are somehow validated. That could be based on previous studies. So there are different types of methodologies and analytical frameworks used in qualitative research. Here I will just focus on 3, but there are many others. Ethnography is a process where the researchers interact directly with the members of the communities in their own day-to-day environment, allowing exploration of a phenomenon in a broader sense to understand the local meaning and looking much more in depth into specific study research questions. It takes much more time, but it gets much more in-depth and rich data. Then grounded theory is this approach delivered by the sociologists Glasser and Strauss that provides rigorous but also flexible guides that begin with openly exploring and analyzing inductively data, leading to the developing of a theory based on the data. And then we have thematic analysis, that is the process of identifying patterns or themes within the qualitative data, within the narrative words or topics that we might have from participants' responses. And this can be inductive, deductive, or both. It's usually used like using both approaches. During qualitative research, something that is very different from quantitative research is that there is an iterative process of data collection and analysis. So you collect the data, you analyze it, and you keep collecting and analyzing. While in quantitative research, you would do all the data collection, not to bias yourself, and then at the end, you would do the data analysis. We do this in qualitative research because it's very important to keep analyzing the data and see if there are new themes that are arising from the interviews, and maybe we can change the guides, include more questions for the following interviews. It's very important to mention that the guides in qualitative research are used to guide the conversation. So it's not like a quantitative survey where all the questions need to be addressed. Many times we change the guides during the process because depending on participants' responses, there might be new things that would need further exploration. And it's also very important to practice reflexivity. So researchers need to reflect on how their own background, biases, assumptions, reactions may influence the interview dynamic and the data interpretation. Some of the most commonly used methods in qualitative methodologies are in-depth interviews, semi-structured interviews, cognitive interviews, focus group discussions, and observations. And I'm just saying that with this slide that apart from doing these qualitative methods, we always need to collect a little bit of quantitative data for the sociodemographic survey. So we need to collect anonymized participant data regarding age, gender, ethnicity, educational level, just to provide us a little bit of information about the participants. So when we're talking about in-depth interviews, we are talking about a method in which a researcher leads a focused conversation with an individual who has previously consented to discuss a topic in depth to respond to study objectives. It's usually done with a very unstructured guide or even without any guide, because it's to explore these participant experiences or life stories, talking about how was your diagnosis with TB, can you describe everything that was related to it, and then the researcher is taking notes and audio recording the intervention. It's very important that the researcher plays an active role listening and avoid leading questions or biasing participants' responses like, I don't know, did you feel fear when you were diagnosed, right? So in this way, you are somehow guiding the responses. A similar type of method, but differently in the terms of how it's structured, are the semi-structured interviews. So it's also a one-to-one conversation between a researcher and a participant, but here we use a predefined topic guide with open-ended questions, such as the ones that I was showing earlier, to prove deeper understanding of a topic. Here we have some themes, or we might have a structured guide with some themes, but might be changed depending on the participant natural dialogue. So the guides need to be adapted to the local context. They also need to be adapted to the language used by the participants, so it's not the same conducting an interview to a healthcare provider than to a high-level stakeholder or to a participant from the general public. We need to use different terms, and also sometimes we need to adapt the local languages. It's preferably always to pilot the guides before conducting the data collection, because in this way you can see how long it takes, if there are some questions that are difficult to be understood, and you have some time to adapt it. Then we have the cognitive interviews. This is a qualitative method in the form of a very structured interview with a participant to provide some responses to optimize an instrument design. So this is most commonly used for manufacturers to improve instructions for use or dissemination materials. For example, you can see in this picture a participant looking at some test and answering some questions about what do they think about the instructions, if they would understand what the test mean or not. So this is the data collection used a very structured questionnaire, like an Excel file or something similarly, to evaluate the clarity, readability, and ease of the understanding of the materials. So it's a qualitative method, but with a very structured data collection form. These are usually performed to assess whether all the steps and the key messages of the process can be understood and easily followed by an untrained user. So participants are given time to read the material, the instructions for use, or any material that we would like to assess understood. And then they will be asked some questions to see if they understand this or not. Then, after all the interviews are done, a rapid qualitative analysis is usually performed. And here we can see an example. What do you think about the instructions? Please tell me in your own words what instruction number 1 is telling you to do. How clear is the image? How clear are the instructions? How could we modify it or reword it to make it clear? And then the researchers would, apart from audio recording the interviews, will be taking notes in a diagram such as like this or similar to see if participants understand all the steps from these processes. This is usually done, for example, with laboratory staff or with healthcare professionals, or also with potential end users in the case of self-testing. Then we move on to another one of the most common qualitative methods used, that are the focus group discussions. This is a method in which a researcher or two moderate a discussion with different individuals, usually from 6 to 8, that are selected purposefully because they have something in common and they would like to explore this topic. This is used as well with a guide and can include interactive activities such as ranking exercises, mapping, using poses to respond to questions, and to engage individuals in the group. It's very important to consider that there might be some power dynamics in some countries. For example, if you have gender mix focus group discussions, sometimes women might not be talking so much in front of men, or it can happen as well if you have people from different ages. Senior participants might talk more, and maybe you will need to somehow include the young individuals in these conversations. This is an example of a focus group discussion where we had to discuss about different types of self-tests, HIV and hepatitis C, HIV and hepatitis B and C, and another one. And we would do like a mapping exercise with participants asking what is the test that would be ideal for you, how can this be implemented, what would difficult, so here, what are the barriers, what are the pros for this specific test, and they would need to put some explanation of this, and then this is discussed within the group. The last methodology that we are talking about today is the observations, and this is a systematic watching of participants in or people in their own setting, conducted in this natural setting where the phenomenon is happening. So, for example, if we are talking about the implementation of this AI tool in the healthcare system in a specific center, we would be there seeing how this works, if people interact with the system or not. The researcher here would take field notes in real time, and it can be from non-participant to full participant. Researcher decides how to involve with the people, if they would like to somehow interact or not. It takes time. Trust and access must be built before these observations begin, because if we have an observer from totally outside the organization, it might create some barriers. These are some of the methodologies that are used for data collection. So every time that we are doing interviews, we try to do some of this to think aloud. For example, asking the participant, what comes to your mind when you think about tuberculosis diagnosis? To check for comprehension, like what would you say is? Also probing, like why did you select this answer? Why did you say so? But there are many others, like paraphrasing, like repeating what the person have just said, or confidence rating. How sure are you about that, about what you just mentioned? These are some things that the qualitative researchers always try to incorporate into each of the interviews or focus group discussions. Important to mention as well that in qualitative research, we usually use saturation. That is when no more data or no more information is added. So instead of doing a sample size calculation, we just use a saturation point to know when to stop data collection. So it's not about numbers, it's about the richness that we have in the information. As I was mentioning earlier, we are doing data collection and then data analysis at the same time. So during this analysis, we can already see if there are no new themes. So if we are conducting interviews and we are getting somehow similar responses from different participants, we can say, okay, we've reached saturation. And this is an ongoing process. So in qualitative research, we are talking about participants or people's experiences, something that they've experienced with their own diagnosis or any caregiver or someone in the family, their perceptions or thoughts, what do people think about that, their behaviors. So we can be asking them, how would you behave? Or if you had been, I don't know, if you had fever in the past, did you go to the healthcare doctor or traditional medicine or not? About feelings, how did you feel about something? But it's also very important to see the body language while we are conducting the interviews and the tone of the voice. Also important to be aware of the researcher's own biases during and after the interview, these power relationships that might affect data collection, especially in focus group discussion, and important to engage everyone in the conversations. Some very specific tips for data collection is to actively listen to participants' responses, to take notes, to skip questions if they've already addressed this somehow, to repeat with other words what participants mention, to make eye contact and note if possible. And things that researchers shouldn't do is only ask the questions in the guide. So again, I'm repeating this, but this is not a survey. This is not a quantitative questionnaire where you will need to fill out all the responses. You don't need to follow the same order as in the guide or seem distracted by writing notes or checking the recorder or your phone. Don't bias the responses. So allow for some flexibility and don't judge others' responses. There are some tasks that needs to be considered before conducting qualitative research, and is the type of method to be used depending on the objectives. Will we use focus group discussion because we want something to be discussed within the community, or we would like to go to a topic in depth and maybe this is very sensitive. So if we would like to talk about HIV diagnosis, for example, we wouldn't be choosing like a focus group and maybe we prefer to talk to a person one by one. Then about the format of the interview, always it's preferable to conduct them in person, but sometimes due to different things, such as, we had the COVID pandemic some years ago, but also depending on resources, we can do the interviews online. It's very important if we do them in person to choose the right location, that it's private, and that there might not be interruptions. Important to audio record the interviews to facilitate the transcriptions. Also the languages that will be used, is it English or local languages or others? Important to know as well the roles that we might need. So will it be one facilitator or two facilitators, someone observing how the focus group is being conducted, someone taking notes? Then after the interview, we'll be writing some notes or memos in paper, in a computer. We'll need to do the analysis, and we'll need to decide the type of analysis that we would like to do. And if we decide to do coding on the transcripts, we'll need to start and decide the type of software that we would like to use. There are many different qualitative softwares. Here I just have three, NVivo, Deduce, MaxQDA, but there are many more. We would like to see if we would like to engage participants to receive feedback from them. So once we have the transcripts, for example, and a preliminary analysis, we can go back to the community and ask them, these are the findings, what do you think about them? And then finally, the report writing. There are two other themes or approaches that I would like to discuss with you, because this might be also used within the AFRICAI-RI project. One of them is participatory action research, that this is where the persons that are being studied are involved in all the phases of the study. So from study conception, study design, protocol design, the design of the data collection tool, the analysis and the interpretation, they are involved in all of that. So researchers and individuals from the community, they share together and they learn together. It's not that researchers take the data from the participants and that's it. It's a much more equitable solution, especially in global health. And the objective here is to change the social norms and to include this justice. Then we're talking about mixed methods approach. So we've been talking about qualitative research a lot and a little bit about quantitative research. So the mixed methods is a research in which the investigator collects both types of data and integrate them into a single study. So it's very important to mention here that this is this systematic integration of findings, because many times people just do surveys, interviews, and then they publish the results separately. But it's a pity not to integrate. And for example, if we have a survey on acceptability and we have, 70% of participants would not accept this implementation, then within the interviews we can explain the whys. So why do people do not accept this intervention? So we've been talking about different approaches. in my opinion, implementation science acts as the umbrella here, and this is asking what works. Then we have the qualitative methods that ask the whys and the how this works. Then quantitative would ask the specific measurement. So mixed methods approaches are used to integrate these quali and quanti methods. And then the participatory action research activities ensure that we ask the right questions together with those that it matters most to, so from the community. So from implementation science, mixed methods, and everything that we've seen, now we would like to show you what the implementation science component is looking like in the AFRICAI-RI study. So we are conducting this study, a Pan-African research infrastructure for biomedical imaging and artificial intelligence in respiratory care and implementation science protocol in 9 participating countries: Ethiopia, Mozambique, Uganda, Gabon, Nigeria, Senegal, The Gambia, Malawi, and DRC. The study design, this is a mixed methods study within the implementation science component, conducted to explore the barriers, facilitators, and implementation outcomes for the integration of this OpenAI repository. We are using here the implementation outcomes framework by Enola Proctor et al. With the 6 key components such as acceptability, appropriateness, feasibility, adoption, penetration, and sustainability. And you have here the definitions for our study. But it's basically stakeholders' perceptions that the intervention is satisfactory, the fit of this intervention in our given context, the potential uptake, and many others. We will be also using the consolidated framework for implementation research to identify and analyze the contextual factors influencing the implementation. And this will be exploring the determinants across the 5 domains, as we explained earlier: the implementation, outer setting, inner setting, individuals, and implementation processes. And this will help us also capture the barriers and facilitators affecting how the OpenAI repository, how the intervention is being perceived, adopted, and sustained in the long term in our study context. So within this mixed methods study, we'll be conducting 3 phases, 3 stages. The first one is a stakeholder mapping to identify local and international stakeholders to be engaged during the AFRICAI-RI study according to different levels of influence and interest. Then we have stage 2 that talks about the formative assessment to explore participants, healthcare providers, and stakeholders' perceptions, and also to identify or explore the barriers and facilitators for this repository. And the stage 3, which talks about the participatory workshop to provide a platform for dialogue, validation of findings, and collaborative decision-making to strengthen the local ownership and contextual relevance of our study. The aim is to inform, support, and provide continuous feedback to optimize the design and the functionality of the AFRICAI-RI platform. And there are specific objectives to map the relevant stakeholders, to explore the perceptions, to assess the barriers and facilitators, and to refine the platform, decision support tools, and reporting outputs based on experts' feedback. So for doing that, we have established that we will have the AFRICAI-RI participants, the adult participants, and the caregivers, and with them we'll be conducting some focus group discussions for all the participating countries. Then with healthcare providers, we'll be conducting as well focus group discussions, and with the stakeholders, we'll conduct semi-structured interviews and focus group discussions, depending on the type of stakeholder that I'll be showing it right now. So we've categorized the stakeholders based on different groups, such as the ethics committee members, policymakers, so the ELSI, ethical, legal, societal implications. Then we have also the healthcare group with healthcare managers, clinicians, clinical researchers, the civil society, very important to have always a voice from the citizens, patient advocates, advocacy organizations. Then the scientific field, we have AI researchers, PIs of the existing project, and others. And we have the industry, so radiology AI companies, funders, AI developers, and many others. So for the first stage, we've started completing a survey by all consortium partner members, and it's been analyzed using the WHO framework for stakeholders mapping. And right now we are working on an SOP to be used for the stakeholder mapping by all countries and by the consortium to engage in communication with the stakeholders. And this would be an ongoing data collection. So every time one of our members would like to say that they've one new stakeholder to be included in this consortium stakeholder mapping, we'll have the online link to access. We've identified so far 71 stakeholders from 19 different countries. 67%, almost 68% of them were men, so we'll need to pay attention to the gender and potentially include more women. And 50% were academics. So again, here we are a little bit biased by our own research networks, and we might need to include more people from the industry, healthcare, LC, and civil society groups. And in green, orange, and red, you can see the consortium members from the AFRICAI-RI. So we will conduct stage 2, which is the formative assessment to respond to the objectives 2 and 3. And as I was mentioning before, we'll conduct semi-structured interviews, focus group discussions, but also quantitative surveys, because this will be a mixed methods approach for acceptability, appropriateness, and feasibility of the intervention, and also observations to document the real-world implementation of the clinical study. We'll be analyzing the qualitative data using the DOS or any equivalent software and following thematic analysis. And the analysis will be conducted at the country level, and then reports will be shared for multi-country analysis report. The last stage would be these participatory workshops that will be conducted to gather feedback from stakeholders in the countries, to gather their perspectives, integrated into the project design, policy alignment, and sustainability planning. And it's important as well to refine the interface, decision support tools, and reporting outputs. We'll be compiling the narrative summaries at the country level, and participants will be filling out a pre-workshop and a post-workshop survey to capture quantitatively the feedback that they've what they've learned from the workshop. If possible, we'll be conducting these workshops in person if resources allow, and if not, we can conduct them online. Regarding the data analysis, narrative summaries will be collected by the partners and will undergo this thematic analysis, and then for the quantitative data from the pre and post workshop surveys will be descriptively analyzed using standard statistical softwares. There might be potential challenges to our study regarding budget implication, timelines, delays due to ethical approvals, or delays with the clinical study, lack of engagement from stakeholders, or even insufficient representation from different geographical areas, across genders, groups from stakeholders, as we've already seen, and areas of expertise, and many other challenges that we might encounter. But we are working on potential mitigation strategies. And regarding dissemination, we aim to disseminate the results to different audiences, including study participants and also for the general public, then stakeholders, for example, at the workshop, and also this continuous stakeholder engagement, and to the scientific community, resulting in abstracts to be submitted to scientific international conferences and manuscripts. And that was all that I wanted to present. I know it's a lot of data. I have some references here in terms of implementation science and qualitative research methods that might be useful. And thank you very much for your time, and we are open for questions. Thanks a lot.
Thanks a lot, Elena. It was so rich, and I learned a lot about qualitative studies.